My name is Amy Donegan. I'm a nurse practitioner at Nationwide Children's Hospital in Columbus, Ohio, and I'm part of the Center of Pediatric and Adolescent Inflammatory Bowel Diseases. So my talk today is on pediatric health maintenance supervision and transitioning to adult care. So let's see here. So things that I'm going to talk about today are really many of the same topics that Mary Kate just spoke about, but I'm going to try to take the pediatric spin on things and not repeat the same information that you just heard. So today, with our health maintenance considerations, I'm going to be talking about growth and nutrition, puberty, bone health, immunizations, eye exams, skin screening, psychological assessments, and then transition of care to an adult GI provider. I'd also like to start my presentation with the Crohn's and colitis resource for the health maintenance checklist in pediatric IBD patients. As I started doing our health maintenance clinics, this was something that I downloaded, had it on my computer saved, took it to the clinic with me so that I always knew what things I needed to make sure I covered with my patients during a wellness exam. And if you are like me, and I hope that you can indulge me for the next few minutes, but when people say, oh, go to the website, you can find these great tools, sometimes I can't find those great tools. So I just wanted to walk through where some of these great resources are on the website. So if you go to the Crohn's and colitis homepage, go to the professionals tab, you can see on the right, the nurses and advanced practice providers education, and then the health maintenance checklist. So if you click on the nurse practitioners and nurses and advanced practice providers, you'll see the best practice resource library. This contains a lot of information, but specific to this talk, you'll find the health maintenance checklists for your patients. You can just click those links and they're there at your fingertips. Another way to get to those same tools is on the left-hand navigator. You can just click on the health maintenance checklist, and this is what will pop up for you. I do want you to notice that the health maintenance checklist for pediatric patients is what I pulled up, but for those pediatric providers that are here on this telehealth conference today, there is a health maintenance technical guide for pediatric patients, which has been newly updated, and it is really, really a fantastic resource and worth everybody going to this to make sure that they have the latest tips in caring for their patients. All right, so to get started with the meat and potatoes about things, we're going to talk about growth and nutrition. So we know that symptoms and clinical features of IBD in adults and adolescents are really similar in presentations, but there are two factors that are very specific to pediatric care, and that is growth failure and delayed puberty. And in pediatrics, we think of growth as a hallmark of health in children and adolescents, and growth failure is one of the most important complications that we see in pediatric IBD. Up to 35% of children with Crohn's disease and 10% of those with UC present with impaired linear growth. And so broadly, growth failure is defined as decreasing height percentiles over time, or that the child's predicted height is substantially lower than their genetic potential. And this aspect of care is so important in the pediatric IBD population that pediatric gastroenterologists actually created their own pediatric version of the Montreal classification called the Paris classification that gives a little bit nuance to those specific pediatric indicators that are not seen in adults, growth and malnutrition being part of those. We know that if somebody is malnourished, it can also cause delayed growth. And so we pay attention to our nutritional status of our patients. Weight loss is noted in 40 to 90% of patients with Crohn's disease and 20 to 25% of patients with ulcerative colitis. When we think about malnutrition and systemic inflammation, we know that these two factors reduce the circulating insulin growth factor 1, which is a major mediator of growth failure and inflammatory bowel disease. There are many reasons why our patients may have malnutrition, but the most common reason is inadequate caloric intake. And we can see that because sometimes eating foods will increase patients' symptoms, abdominal pain, cause more diarrhea. But we also know that we are identifying more and more patients that have developed ARFID, or avoidant restrictive feeding disorders. And based on a screening exam, we can see that these ARFID type behaviors can exist longer term, even when patients enter remission. There is a component of maldigestion that can occur and can contribute to weight loss. That can be seen in patients that perhaps have an enteroenteric fistula, or if they have extensive small bowel inflammation and can't digest their nutrients correctly. And then we also have fecal nutrient losses, which can include carbohydrates, fats, and proteins in our stool. So it is recommended at each visit that we check the height, weight, and body mass index at all of our health maintenance or all of our office visits with our patients. I want to take a minute to talk about the utilization of Z-scores as we are monitoring height and weight and BMI of our patients. So a Z-score is essentially the number of standard deviations above or below the normal distribution pattern. And it's helpful for us in monitoring incremental growth changes. An example would be a Z-score of 0 would equate to the 50th percentile on the growth curve. A Z-score of minus 1.89 would be the 3rd percentile, and a Z-score of plus 2 would equal the 97th percentile. There are many different ways that you can monitor and measure Z-scores. You can use a single data point, you can use multiple data points, but just for point of reference, say we're going to look at the BMI for age Z-score, and our patient's Z-score is minus 1.5. We would know that that patient falls under the mild malnutrition category. If their Z-score is minus 2 to minus 2.9, they'll have moderate malnutrition. And any Z-score greater than minus 3 is indicative of severe malnutrition. So as we think about not eating foods, restricting foods, excessive losses, it stands to reason that our patients can develop micronutrient deficiencies. So it's important that we routinely monitor for these deficiencies because they can occur with chronic blood loss, intestinal malabsorption, decreased intake, and chronic inflammation. Our patients are at increased risk for iron, folate, vitamin B12, zinc, and vitamin D deficiencies. We can also do a stratified approach to kind of think about what micronutrient deficiency our patients are at risk for by assessing where their inflammation is. So in a patient that has proximal small intestinal inflammation, there may be an increased risk of iron and calcium malabsorption. In a patient that would have diffuse small bowel disease with profusive diarrhea, they may be at risk for zinc deficiency. In somebody with extensive ileal involvement, we would be worried about folate and vitamin D, or vitamin B12, excuse me. And in somebody that has severe colonic disease, we would think that maybe there could be ongoing chronic blood loss, and we would need to think about iron deficiency. So the recommendation is that the vitamin D should be checked every 6 to 12 months. If you're going to check it only once a year, that should be done between October and April, because in the United States, that's when we're more inclined to have the lowest levels of vitamin D that we'll have in the year. We also recommend routine checking of iron studies, such as iron saturation, TIBC, and ferritin. So we know that iron deficiency can occur with or without anemia. So just having a normal CBC isn't sufficient enough. We check CBCs quite frequently, every 3 to 4 months. We usually check iron studies once a year, and more often if those are noted to be low. There is significant amounts of data now to show that iron deficiency without anemia can still lead to active symptoms such as restless leg, fatigue, migraines, brain fog. So we really want to make sure that we are scheduling times that we are checking our iron studies. And if you are in a facility or have access to a registered dietitian, we recommend our patients get an evaluation by the dietitian once a year. So let's move on to pubertal delay, the other hallmark of pediatric IBD extraintestinal complications. So we think about delayed puberty as having many factors that can contribute to this. And I've spent some time discussing malnutrition and inflammation. Those both can drive growth impairment, which eventually leads to pubertal delay. And when we think about defining pubertal delay, it is defined as pubertal onset occurring outside of the range of what would be normal by at least a delay of 2 to 3 standard deviations. So in the United States, what that would mean is that the upper limit of normal pubertal development is approximately 12 to 13 years of age for females and approximately 13 to 14 years of age for males. We also know of an entity which is called stalled puberty, where we may see that our patients were entering puberty, then they develop inflammatory bowel disease, and their pubertal progression just stops for 2 to 3 years before it restarts. So in looking at this broadly, we know that malnutrition and inflammation cause interference with growth hormone and insulin-like growth hormone factor 1. We know that there is an interference with gonadotropin releasing hormone secretion patterns. We know that inflammatory cytokines have a direct effect on bone growth. And in our patients who are malnourished, we see that decreased fat can lead to lower leptin concentrations, which can lead to gonadotropin deficiencies, which decrease LH and FSH secretion, which then cause depressed estrogen production and secretion, leading to pubertal delay. Why is that important? So somebody starts their menses or grows facial hair at 16 instead of 12. Well, we see that 25% of our patients with IBD are diagnosed before the age of 20. This can have a significant impact on puberty and the pubertal growth spurt. And it occurs in 10% of patients with inflammatory bowel disease. As you would expect, it's more common in patients that are diagnosed with Crohn's disease. Pubertal delays, as I mentioned, are associated with low weight. And in a study by Amaro et al., they noted that there was a statistically significant delay in menarche in patients presenting with Crohn's disease compared to healthy children without inflammatory bowel disease. It's therefore recommended that Tanner staging is done routinely beginning at the age of 9 in girls and at the age of 10 in boys. What do we do when we find pubertal delays in our patients? We have several things that we think about, but our target really is normalization of growth and development. And so that is our treatment goal. And we do that by treating inflammation and malnutrition. One way that we can make sure that we're doing that is to try to avoid steroids at all costs. And sometimes as we are walking through causes of pubertal delays, we may need to get some additional testing. We could consider a DEXA scan. And there are also times that we have needed to refer patients to endocrinology for additional support and diagnostic testing. Delayed puberty also affects bone mineralization density. 10 to 40% of patients presenting with inflammatory bowel disease have bone mass deficits. And we see that more frequently in Crohn's disease as compared to ulcerative colitis. Adolescents have peak bone mass, and that's the best predictor of long-term skeletal health. So the majority of our bone mineral density accrual occurs during adolescence. After you're past the age of 20, bones are breaking down faster than they are building. And we know that low bone mineral density in adults is associated with increased fracture risk. So how does inflammatory bowel disease impact bone health? Well, we see that it can slow bone growth. A poor appetite leads to poor nutrient intake. Good energy and physical activity is important for bone development. So those great weight-bearing exercises are what helps us accrue bone mass. And if our patients are not in remission, feel lousy, and are just laying on the couch playing video games all day, we see that this is a large contributor to decreased bone mineral density. Many of our patients don't tolerate dairy after being diagnosed, so they're missing out on getting calcium and vitamin D. They may have poor absorption of their nutrients, even if they're eating well. And then steroids has a direct impact on bone mineral density. The one thing that I would say is that if there is a silver lining, we do know that bone mineral density is associated with delayed epiphyseal closure, which may permit catch-up growth in some cases. There's a lot of variability in the recommendations of when to obtain a DEXA scan. So the DEXA scan, our bone density scan, is a really good way to assess bone health. So the Society of Clinical Densitometry recommends that children with IBD receive a full body DEXA scan minus the skull at diagnosis, with repeated measures no closer together than every 6 months apart. There is recognition that there is radiation exposure with this X-ray, but it's very low. Other providers may say that they'd like to do a baseline scan at diagnosis and then repeat every 1 to 2 years thereafter. And there is another group of us that stratify risk factors for having low bone mineral density and just check on a case-to-case basis. So if we're looking at those factors that increase your risk of low bone mineral density, it would include poor linear growth, lean muscle mass deficits, irregular menses, delayed puberty, a severe inflammatory disease course, and prolonged steroid use. How do we treat poor bone health? Well, the first and foremost thing that we have to work on is achieving disease control, and then we can optimize nutrition. Many people will need supplementation with calcium and vitamin D. As soon as we can, we are encouraging our patients to begin weight-bearing exercises. And depending upon your institution, we refer some patients to our bone clinic, which sometimes is staffed by endocrinology and sometimes by nephrology, and that would vary center to center. So I'm going to move on to immunizations, and Mary Kate did a really great job of reviewing all of the recommendations surrounding avoidance of live vaccines. I don't think that we can get this list of vaccines in our faces enough, so I wanted to include those live virus vaccines that are available to our patients that we need to consider. To reiterate what Mary Kate had said, immunosuppressive therapy should be discontinued for at least 3 months before we would administer a live vaccine. If somebody is on corticosteroids, we would discontinue that 1 month before we administer live vaccines. And say our patients aren't acutely ill and would like to get a live vaccine, if we would give it, we would need to be able to wait for 4 weeks before we would start immunosuppressing therapy. This is one of the cases in the pediatric realm that we use exclusive enteral nutrition, as that can be very effective at maintaining remission in patients that have moderate Crohn's disease. So we'll often use that as a bridge as we are waiting to start immunosuppression because our patients wanted to get a live vaccine. Based upon all of the conversations that we've had today about vaccinations and the schedules and the complexity and who gets what, one of the things that we started at Nationwide Children's was that we would refer all of our newly diagnosed patients to our infectious disease host defense vaccine clinic. This has been a huge revelation for us because in our GI clinic, we don't carry many types of vaccines. In the infectious disease clinic, they have all of the vaccines that they need available for them. And we used to tell our patients, and write in our discharge summaries, we would say, go to your pediatrician and let them know that you need X, Y, and Z vaccines. And that would rarely happen because we know our pediatrician colleagues don't really feel comfortable giving vaccines in patients who are immunocompromised. So the host defense clinic is really a very good option if that's available to you. The other thing that we should think about in our patients who may travel internationally is making sure that they are referred to an international travel clinic. We also have that as part of our host defense clinic. And so any of our patients that are traveling are referred there. They are the experts in vaccination. And I think it's just important for our patients to hear directly from the experts what vaccines are recommended for them. This is from the CDC. It's just the recommended vaccinations birth through 6 years of age. And for our adult counterparts, this isn't something that you think about, but we do have a diagnosis called very early onset inflammatory bowel disease. And so these vaccines are really important for us to consider. While infantile IBD is really exceedingly rare, there are going to be some patients that can't get their 12-month measles, mumps, and rubella or varicella vaccine. But things that I mostly think about with our VEO IBD kids are this 4 to 6 year range of our recommendations for vaccination. And specifically, we think about getting the second or the booster MMR and varicella vaccine. This is directly going to impact what our patients are going to need, the parents for school, because the schools are going to want to see that they have their vaccinations up to date. And this is just not something they're going to be able to do. So counseling early for our parents is very helpful. The other indication that is different from the adult population is the HPV vaccine, just essentially that it's recommended starting at 9 years of age. And if you receive the vaccination before 15 years of age, then you'll only have to get 2 of the vaccines instead of a 3 vaccine series. Just looking at hepatitis, we should be checking at diagnosis hepatitis B surface antibody. We also check an antigen and core just in case there was some exposure that didn't quite, that was developing as we were checking our antibodies. We recommend checking a hepatitis B status on our patients, or hepatitis C status on our patients that are greater than 12, not because there's any vaccine available, but because it would alter our consideration and what kind of immune suppression we may offer our patients. So if a patient is not immune to hepatitis B when we do the hepatitis B surface antibody check, we recommend repeating the complete 3-shot series. We know that hepatitis B loss of detectable antibodies ranges from 13 to 60% 9 years after their initial vaccine series, which is usually in the first 6 months of life. At our institution, we did years of tracking hepatitis B response, and we saw that we were outside of that 13 to 60% loss of response. And we had 80% of our patients that no longer displayed immunity to hepatitis B. So in part of our efforts to get our patients vaccinated before we used the host defense clinic, we would give one hepatitis B vaccine in the clinic, and then we would tell our patients that they should go back to their primary care providers to get the additional 2 vaccines. And what uniformly came across was that the pediatricians would say, well, you've already received this vaccine, so I'm not going to give the other 2. We don't really understand why we're revaccinating against this. In those patients, we started to check again to see, well, gosh, did one vaccine give them enough immune suppression? And uniformly, it did not. They were still non-detectable for their antibodies. When we repeated the 3-shot series, there was a 92% response rate. So that is our standard here at Nationwide Children's. If a patient is older than 18 years of age, you can use the HepliSave B vaccine, and that's a 2-shot only series. Tuberculosis is also something that we need to consider screening for. So at diagnosis, we check for tuberculosis because we know that we will be suppressing the majority of our patients with an advanced biologic of some sort. And we know that the biologics can cause reactivation of latent TB. So we usually try to screen for 2 measures of tuberculosis. The most effective way of screening is through the IGRA testing, which would be the quantiferon TB, or in our younger patients, the TB T-spot is recommended. And then we recommend using a TB screening questionnaire, or if we haven't started steroids, considering placing a PPD. One thing that I did want to note, because there can be so much frustration with quantiferon TB results being indeterminate and needing to be repeated, and often on that lab result, it says can't determine if there's been exposure, repeat in 3 weeks. And we usually can't wait 3 weeks before we want to start treatment for our patients. So it is important to note that the quantiferon TB is really a tricky test to collect. And if it isn't collected appropriately and gotten to the lab in time, that in and of itself can lead to an indeterminate result, and not that we are worried that our patient has developed tuberculosis. We also think about cervical cancer screening. Women with inflammatory bowel disease have a higher risk of cervical cancer, and currently that cause is unknown. We know that with routine pap smears, there's been a significant reduction in mortality from cervical cancer. So we recommend, because the major cause of cervical cancer is related to the HPV virus, as we've said, it is recommended that our patients get hepatitis B vaccine. The AAP recommends it for all children. It is safe. It is not a live vaccine. And if we can start it when they're younger, then they only need 2 shots versus 3. Skin screening is also another thing that we need to consider, because we know that immunosuppressing medications have an increased risk for melanoma and non-melanoma skin cancers. And when we think about the non-melanoma skin cancers, those are more common in patients that are on steroids, thiopurines, methotrexate, anti-TNFs, and the JAKs. Really, it's not a significant signal for increase in those that are on the anti-integrins, the IL-12/23s, or the S1Ps. Melanoma skin cancer is more commonly associated with the anti-TNF use. So we recommend annual skin screening for our patients, and we also educate them to wear sun protective clothing if they're out in the sun for prolonged periods of time, to use sunscreen with SPF of at least 15, and to limit their outdoor exposures between the hours of 10 and 4 during the summer months. Eye exams are also important, and when you talk to your patients about this, you need to stress that you're not concerned about visual acuity, but more about the health of the eye. Because more times than not, when I've asked patients if they have been getting eye exams, they say, yes, my primary care doctor does it every time I go in for a well checkup, or I get this done at school every year. I have to educate a lot that what I'm requesting for an eye exam is different than what can be provided in those two settings. Ophthalmologic findings occur in 4 to 10% of patients as an extraintestinal manifestation of IBD. And this is more commonly noted in patients with Crohn's disease and those that have arthralgias. Uveitis occurs in 1 to 6% of our patients, and it can be asymptomatic. It can also present with eye pain and headache. It's more common in Crohn's disease compared to ulcerative colitis, and it is independent of disease activity, whereas episcleritis often parallels IBD activity. So patients are having a flare, and then they develop acute redness, irritation, and watery eye. Usually no visual disturbances are noted, but episcleritis is one of the most common ophthalmologic conditions associated with IBD. You can also see the other things that I have listed that can be found, such as conjunctivitis, scleritis, marginal keratitis, retinitis, retinal vascular occlusive disease, optic neuritis, and orbital inflammatory disease. We recommend that our patients get a routine eye exam at baseline and annually thereafter. Psychological screening is very, very important. We know numerous studies that have shown that children with IBD are at increased risk for altered psychosocial functioning, including depression, anxiety, self-image, and social, family, and school functioning disorders. But less than 25% of our patients will display obvious symptoms. So when we walk into the patient room, they may not have a flat affect, they may make eye contact, they may not be crying, but if you were to ask a very targeted set of questions, you would pick up that the patient may be depressed. There are lots and lots of screening tools that you can use to assess for anxiety and depression and quality of life. So we recommend picking one that you become familiar with and giving it to your patients to complete at least once a year. There are also some screening tools for parents to complete on how they assess their child. And so those are also, I feel, worthwhile using once a year as a screener. Tobacco use. Tobacco use is a pediatric problem. And I want to say that again, it is a pediatric problem. The side effects, the negative impact of smoking occurs in adulthood, but 90% of all adult smokers started smoking before the age of 18. And we've heard several of the people who are presenting at this conference talk about how harmful smoking is in patients with IBD. Smokers have a 2 times higher risk of developing Crohn's disease than those who have never smoked, and increases your risk for disease flares and for recurrence of inflammatory bowel disease after surgery. So we really need to start at a very young age talking about the harms of smoking. It's usually easier to never smoke than to smoke and try to quit. So if in our realm of the pediatric world, we can hammer that information home, we may have more success as our patients get older. E-cigarettes are so commonly used in the younger population. We don't have a lot of data specific to inflammatory bowel disease like we do with cigarette smoking, but we do know that e-cigarettes are harmful to our health, so we're going to say don't smoke. And there is some data to suggest that if patients begin vaping when they're younger, they're more likely to smoke cigarettes when they're older. Okay, so with that, I'm going to shift gears and talk about transition of care. For us transitioning geeks, we will often talk about transitioning and transfer, and they are two separate entities. So transition is something that occurs over several years. You're working with your patients to gain self-management skills. Transfer of care is just that actual act of writing the referral and getting the patient to stop coming to your pediatric practice and go to an adult provider. Transition education should start between 12 and 14 years of age and should focus on self-management skills, including knowledge of disease, medications, lab, what those results mean, adherence, finances, and how to schedule appointments. Those are all pretty difficult things. There are many transition tasks, many checklists available for you guys to track your patient's progress. I think it's important that you identify what checklist you want to use and then just be consistent with that. NASPGHAN has a very good transition task checklist, and Got Transition is another good transition task checklist, or the TRAQ, the TRAQ, Transition Readiness Assessment Questionnaire, is also one that is readily available. At Nationwide, we developed a transition task checklist because what we found when we gave the other checklists that I mentioned, there was significant reliance on knowledge and not actually doing a task. So we would have parents say, oh, you know this, like what is your diagnosis? Or what is IBD? And we really felt like, well, that is important. I want to know that you can actually call and schedule an appointment, or that you can actually call the pharmacy to get your medications delivered, or that you'll actually know what your insurance coverage is and that you're carrying your insurance information with you. Why do we focus on healthcare transition? Well, simply because a child with chronic disease is going to become an adult with a chronic disease. And we know that there is an increased risk for poor outcomes at this time. For those of you who are parents and now have adult children, can recognize that normal transitioning of mainly parental control over what your child does kind of changes in that high school to college years, where the adolescent and young adult are trying to exert more independence, and the parents need to learn to step back. That's hard enough when you don't have a chronic disease. So just another layer of complexity occurs when somebody is diagnosed with inflammatory bowel disease. So we do know through a variety of chronic illnesses that when we try to transfer from pediatric to adult care, we can see that there is concerns for poor adherence, care lapses, worsened disease control, increased utilization of the healthcare system because patients maybe are just going to the emergency departments for their care and have not really established a routine follow-up with the adult primary provider. There's decreased healthcare satisfaction and quality of life. And in some diagnoses, there is an increased risk of death. And obstacles for a successful transfer of care exist at multiple levels. We can see that for the patient and family, there is a lot of reluctance to leave peds. They're concerned about transitioning the responsibility of healthcare to their child or young adult. There's a lack of knowledge and self-management skills. It's important to focus on these factors routinely in health maintenance clinics. The other issue is the pediatric provider, us. It's hard for us to say goodbye to our patients. So we think their patients are only 21. What do adult providers know about taking care of patients who are 21 years of age? We're concerned about the adult provider ability to care for a patient and a psychosocial aspect that we think we provide better care in. And then we think about the adult provider. They may have a discomfort with pediatric patients. They have concerns about the lack of patient knowledge and their own self-management skills, and sometimes the excessive over-involvement with the parents. And then logistics obviously always play a part in barriers to access of care. If we have inadequate staff to make sure that our patients are going to visits, it takes time, there are additional resources that are needed, insurance things, so just the whole process can be a little bit cumbersome for our patients. When we look at transfer and a transitioning program, it's really important that we have a structured plan to transitioning. Gut Transition is a wonderful, wonderful resource if you plan to establish a transition clinic. They recommend 6 pillars as aspects of a transition program. The first is that the hospital, the office needs to have a policy or guide about your transition program, and that needs to be discussed with the parent and the patient at diagnosis. There also should be a registry, a way that we can track and monitor our patient's progress. So if you're giving transition checklists, how are you tracking that from one visit to the next over potentially 7 years? How are we assessing patient readiness? Should probably be a way that we are offering education to these patients on a comprehensive basis, again, over years of time in the pediatric world. And then we need to have a plan with a medical summary. Who are we going to be making the referral to? Do we have all of the health information for the past potentially 10 years from the patient wrapped up in a way that it's easy for our adult colleagues to know what they need to do for the patient as they're assuming their care? And then we have the actual transfer process. There are several hospitals that will that are peds and adult within the same building. It's a little bit easier than if you're a freestanding hospital and you're trying to build bridges with your adult colleagues. And then you want to make sure that your transition is complete, meaning you didn't just write the referral, but that you that the patient actually showed up for the visit and attended. There's a lot of information that I reviewed, and I just wanted to offer one practical tip of what we do at Nationwide Children's Hospital to make sure that we have a system in place that we can implement all of these strategies in a succinct, comprehensive way. So we have developed an annual IBD office visit. It takes place of a routine office visit with their primary gastroenterologist. And as the nurse practitioner, I kind of do the medical piece of the visit, and then I work on the transition readiness. We have a psychologist that is embedded in our clinics, and they do the screening for depression, anxiety, quality of life, look at barriers to adherence. We have a dietitian that meets with our families, and a social worker that helps with finance, insurance, other barriers to care, and assists with school and or work accommodations. So